our patient comes out to be clinical stage 2B. So how is it? So clinical stage 1 is when the T stage is confined to the testis and the nodes are negative. Okay, confined to the testis, and so it is confined to the testis and nodes are negative. But if the nodes are positive, it becomes clinical stage 2. Again, it is 2A, clinical stage 2B, and clinical stage 2C. 2A when it is less than 2 centimeter node, 2B it is 2 to 5 centimeter node, and 2C it is more than 5 centimeter node. Clinical stage 3 is when it is visceral or distant metastasis. So this is the clinical stage. You have to produce a clinical stage in a testicular tumor to come to a management. So MDT will ask you about this clinical stage of the tumor. So once you get a clinical stage, because the patient's tumor was confined to the testis and there was no distant metastasis, and the lymph node was 2 to 5 centimeter, then it is clinical stage 2B. The management for a clinical stage 2 of a seminoma is this. This is very classical. You have to mention that there are two treatment options for a seminoma. So it is either a chemotherapy or radiotherapy. Okay, so these are the two options. There is for a stage 2, there is no option of surveillance. You have to treat the patient. So you treat it with a chemotherapy or radiotherapy. The preferred, as per the guidelines, and even in the UK practice, the preferred is a chemotherapy. You mentioned all the answers correctly regarding the chemotherapy. I'm not going to details of it. So it's a 3 cycle of BEP or a 4 cycle of EP if the patient has contraindication to bleomycin. Okay, the alternative to it is a radiotherapy. Now, what is clinical stage 2A? That means the patient has a small lymph node, less than 2 centimeter. Clinical stage 2B, the patient has a large lymph node, 2 to 5 centimeter. But the chemotherapy, doses, cycles, all remain the same. The only change is when you are planning for a radiotherapy. When you're planning for a radiotherapy, the overall radiation dose is 30 gray for clinical stage 2A. But the dose becomes 36 gray when it comes to clinical stage 2B. The extra 6 gray is given as a booster. The extra 6 gray is given as a booster to the enlarged retroperitoneal lymph node, apart from the standard dogleg regimen. So what is dogleg? Dogleg means the parabiotic is given, and like a leg of the dog, the iliac group of is given. This is the parabiotic, this is the iliac. So it is known as a dogleg regimen. So you give a dogleg regimen standard, it is going to be 30 gray. But if it's a clinical stage 2B, you are giving a boost to the lymph node as well, enlarged lymph node as well, extra 6 gray booster dose, and that makes it 36. So stick to this two basic treatment options for a clinical stage 2. What if the marker is elevated? There is no change if the seminoma is concerned. This will end your scenario here. But if you are very fast, then probably the next question will be the same stage patient with a non-seminoma. Okay, so if you have the same patient and there is a non-seminoma, clinical stage 2. Okay, so now the treatment of a non-seminoma clinical stage 2 is depending on markers. Unlike a seminoma, which is not affected by the elevation of markers. So if the markers are elevated and there is a clinical stage 2, you prefer a chemotherapy regimen, BEP 3 cycles. But if the markers are not elevated and there is a clinical stage 2 non-seminoma, then you go for preferably a retroperitoneal lymph node dissection. Now, there is one important thing. Clinical stage 2 seminoma, again, we have 2A and 2B because of depending on the size of the lymph node, it is less than 2 centimeter, more than, 2 to 5 centimeter. So for a 2B, it becomes obvious, okay, it's a high volume disease probably compared to a 2A. So a retroperitoneal lymph node dissection can be justified. But when there is a very small tumor, less than 2 centimeter, and there is a marker is negative, so if the marker is negative and you have a clinical 2A, there is an option of surveillance. You can keep the patient on surveillance. So this is the scenario. If the patient has clinical stage 2A, that means a small tumor less than 2 centimeter, you can keep the patient on a follow-up. And after 6 weeks, if the patient develops any progression, you go for the treatment. Okay. Otherwise, you can give the option of retroperitoneal lymph node dissection also. However, in a stage 2B, there is no option of surveillance. The only option is a BP if the marker is elevated, the RPL if the marker is normal. Is it clear so far?